Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Domenica Lorusso from the Fondazione Policlinico Gemelli in Rome, Italy, and Dr. Alexandra Leary from Gustave Roussy Cancer Center in Paris, France. They will be discussing key updates for ovarian cancer clinical trials presented at the 2022 ESMO Congress. This episode is part of a larger educational program entitled 2022 Global Conference Coverage, an update on the clinical development across gynecologic malignancies. For more information on Dr. Lorusso and Dr. Leary, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
I'm Domenica Lorusso. I'm a GYM oncologist working at Policlinico Gemelli of Rome, and I'm here with my colleagues and best friend Alexandra Leary, medical oncologist at Gustave Roussy of Paris. In the coming minutes, we will review and discuss with you the most important results which were presented during the ESMO Congress in Paris. I will discuss with you the results of SOLO-1 trial, which was the first randomized trial evaluating the role of PARP inhibitor olaparib, 2 years maintenance of PARP inhibitor olaparib or placebo in stage 3-4 high-grade ovarian cancer with the BRCA mutation. The first results of this trial were presented in 2018 and reported 3 years increase in median progression-free survival. What we had during the ESMO meeting is the update overall survival results at 7 years of follow-up. And it was really impressive to see that after 7 years, 67% of patients receiving olaparib were still alive with respect to 46% of patients receiving placebo. And these results are even more important if we contextualize that after progression, up to 45% of patients initially receiving placebo had a PARP inhibitor. So with a huge number of crossover, the results were still very, very, very impressive. And also in terms of time to first subsequent treatment, the results reported that 45% of patients receiving olaparib versus 21% of patients receiving placebo. And this is impressive considering that these patients probably had not recurred. And the results were good also in terms of second subsequent therapy. And 57% of patients receiving olaparib versus 32% of patients receiving placebo were free of subsequent therapy, thus suggesting that the benefit of olaparib was maintained over time, even at the second subsequent treatment. The toxicity profile was quite the same with respect to the early presentation of data, and in particular, myelodysplastic syndrome or leukemia. And it was quite reassuring to see that was not a worsening in the number of myelodysplastic syndrome and leukemia, and around less than 2%, 1.5% of patients receiving olaparib at 7 years presented myelodysplastic syndrome and leukemia, and the same number was 1.2 at the first primary PFS analysis when the data were presented for the first time. So we did not see an increase of this toxicity, nor in terms of other toxicity in terms of myeloid and non-myeloid toxicity. So I think that these data are really impressive, and I want to see what do you think about this data, Alexandra?
I mean, I think these were the data we were waiting for, which is basically, do we think we might be curing more of our patients by doing this? And although we're going to keep following this with even further and further follow-up, but at least here, I think that you have to remember that we stopped the PARP inhibitor at 2 years. So what we're seeing here, they're not on active treatment anymore. And so I think it's really raising the possibility that we might actually be increasing cure rates. And that's something we've been waiting for a really, really long time.
And we did not never dream that this could happen. So we are really, really exciting. At ESMO were presented also the final overall survival results of the PAOLA-1 trial. PAOLA-1 was a randomized phase trial comparing olaparib plus bevacizumab versus bevacizumab alone in the maintenance treatment of newly diagnosed high-grade stage 3-4 ovarian cancer, regardless BRCA mutation or HRD. The first presentation of the data clearly reported a significant benefit in terms of progression-free survival when olaparib was combined with bevacizumab with respect to beva alone only in HRD patients. HRD signature was evaluated in this trial with the myriad My Choice test. The results of overall survival and a significant increase in terms of overall survival was reported for the first time, I have to say, after several years in this trial, but the benefit was reported only in HRD positive patients. So exactly as for progression-free survival, also overall survival benefit was reported only in HRD positive patients, with the 5-year overall survival increasing from 48.4% to 65.5% in patients receiving the combo of olaparib plus bevacizumab, and a confirmation also in PFS was reported. So it's really interesting to see that the benefit was mainly driven by BRCA mute patients. In BRCA mute patients, a significant increase in overall survival from 54% to 73% was reported. And in HRD positive BRCA wild type, a significant increase from 44% to 54% was reported. Very interesting to me is what happened in HRD negative population, where there is no significant benefit from the combo, but another ratio of 1.2 was reported in favor of bevacizumab single agent. So, and this is my question for you, Alexandra. What is your interpretation of this data?
So first of all, this adds to the fact that we have OS benefit in HRD positive patients, even those that are BRCA wild type. So we have SOLO-1 that confirms it in the BRCA mute. Here we have data that confirms that there's also a benefit in terms of OS for a PARP inhibitor in the BRCA wild type HRD plus. In terms of the HRD negative, I think this study confirms that we need to do some more work with them. Here, beva alone does just as well as a combo, and we don't want increased toxicity. So clearly, single agent maintenance is the best we can do for these patients. But I think we really need to try to do better because these patients don't do as well as our HRD positives. And, we have two options for them, either bev or a single agent PARP inhibitor based on other studies. And I think we really need to focus on doing something better for these patients whose PFS rates and OS rates are always weaker than the HRD positives.
Absolutely, absolutely. This is the population with the worst prognosis, and we have to do all our effort in try to cure this patient. PAOLA-1 was also reassuring at a longer follow-up of 5 years, was also reassuring in terms of safety, and also in this case, exactly for SOLO-1 trial, and no significant impact of myelodysplastic syndrome and leukemia was reported at a longer follow-up. And as you say, Alexandra, this is the first trial in more than 10 years reporting a significant increase in overall survival in the first-line setting of ovarian cancer, and we are really excited about them.
Absolutely. Let me discuss two other studies that were highlighted at ESMO, and it's really all about PARP inhibitors. There was another study called the ATHENA-MONO study. Now, this is, again, in the first-line setting, a phase 3 trial of a different PARP inhibitor. Here it was the rucaparib maintenance in patients with newly diagnosed ovarian cancer, stage 3 or 4, again, regardless of BRCA or HRD status. And this previously reported a significant improvement in PFS with rucaparib compared to placebo alone. Again, this was another study. This is just a PARP inhibitor. There's no maintenance in a control or the experimental arm here. And so they showed a significant benefit in terms of PFS. But what the investigators wanted to do here at ESMO was to try to tease out other clinical factors that can help identify who benefits more or less from a PARP inhibitor as maintenance in first line. And to some degree, this is because of the data we saw with bevacizumab, where there was some suggestion that bevacizumab, back in the day, 10 years ago when we did those trials, was really brought a significant benefit more in very poor risk patients. What did we mean by poor risk at the time? They had to have incomplete surgery, disease left in place, or no surgery whatsoever. And so the investigators in ATHENA-MONO wanted to try to see, could they see a benefit to the rucaparib as maintenance compared to placebo in different clinical risk groups. So the first clinical risk group they looked at is that patients can be enrolled in the study whether they had complete resection or an incomplete resection. Was there a difference in benefit? Well, both groups benefited, okay? Those that had an R0 resection had a very nice hazard ratio of 0.6, and those that didn't have a complete resection had a hazard ratio of 0.41. Now you have to be careful because the numbers get smaller and smaller, but at least that's data to suggest there doesn't seem to be any difference, that both good risk and bad risk benefit from rucaparib. They did the same with response to chemotherapy. I remind you that the randomization is after the end of chemotherapy, and people could be in complete response or partial response. Did it make a difference? Again, both groups had a benefit. Now you have some 95% confidence intervals that start crossing one because they're small groups. So this is just sort of descriptive data. But when they looked across all different things, stage 3 versus 4, whether the patients had upfront surgery or interval debulking, whether they had complete surgery or incomplete surgery, complete response, partial response, all of these subsets benefited, okay? And so really that just reinforced that regardless of the clinical risk factors, patients benefited from maintenance with rucaparib in the ATHENA-MONO study, whether they would be classified classically as high risk or low risk for relapse, suggesting that all of these stage 3-4 patients should benefit from a PARP inhibitor. And here, Keta, what do you think of this? Would this change the way you practice?
Oh, it is quite reassuring, Alexandra, because in Italy, in this moment, more than 70% of patients are treated with neoadjuvant chemotherapy, and this impact on the prognosis. These are really high-risk patients. It's really reassuring to see that we are, in this moment, enabled to identify a clinical biomarker of response to PARP inhibitor, and all patients respond. This is really good for our patient.
Thank you, Keta. So then I'm going to close on a last study, and this was overall survival results from ARIEL4. Now here, this is a phase 3 trial evaluating rucaparib as treatment, not as maintenance, versus chemotherapy in patients with relapsed ovarian cancer and a deleterious BRCA 1 or 2 mutation. So here, a very different setting. We're in the relapse setting. And the PARP inhibitor is not given as maintenance after chemo, but as treatment and compared to standard of care chemo, okay? Just to remind you of the design, so these patients, BRCA mutated, relapsed, high-grade ovarian cancer, they could be relapsing less than 6 months from their platinum, so-called platinum resistance, or relapsing 6 to 12 months or more than 12 months since their platinum. And depending on whether they were relapsing resistant, partially sensitive, or fully sensitive, they received weekly paclitaxel if they were resistant or partially sensitive, or a platinum-based chemo if they were fully sensitive, and that was for the control arm. The experimental arm for all 3 of these was rucaparib, again as treatment. Now, this study actually reported their results previously and showed a benefit in terms of PFS for rucaparib as treatment versus standard of care chemotherapy in these patients with quite heavily pretreated BRCA-mutated cancer. And here they were presenting at ESMO the overall survival data, okay? In terms of baseline characteristics, again, so this had a sort of a mixed population since they included platinum resistant, platinum partially sensitive, or fully sensitive. They were quite heavily pretreated, had prior 3 to 5 lines of chemo. And they were randomized to a standard of care chemotherapy, weekly Taxol, or a platinum versus rucaparib. Importantly, if they were randomized to the chemotherapy or standard arm, they could cross over to rucaparib. And so just to let you know, among all those who were randomized to standard of care chemotherapy, over 90% of them, when they progressed, crossed over to rucaparib post-progression. The investigators also followed what the patients in the experimental arm, so those that were randomized to rucaparib, and almost 50% of them went on to even have a platinum chemotherapy after their PARP inhibitor. Now, what was the overall survival analysis in ARIEL4? Well, there was a trend for better overall survival for the patients randomized to standard of care chemotherapy. So while PFS was in favor of rucaparib, OS was in favor of chemotherapy. Now, this was probably not statistically significant, but let's say that we clearly didn't have a benefit in OS that we saw in PFS. They tried to decipher which was the group that seems to do less well when randomized to rucaparib. And basically, in terms of OS, it was the platinum-resistant population, which in terms of overall survival benefit did worse in the rucaparib arm than in the standard of care chemotherapy. Now, are these results completely surprising? I think all of us are slightly concerned that patients who progress under a PARP inhibitor aren't going to do as well with subsequent chemotherapy, especially probably platinum, just because the resistance mechanisms are probably there's a certain amount of overlap in terms of resistance. So basically, this study was here to validate preliminary data from phase 2 studies showing that there was a benefit to using a PARP inhibitor, rucaparib, as treatment for heavily pretreated BRCA-mutated ovarian cancer. And if you look at the overall survival results from ARIEL4, it seems that we were not able to show that there's a benefit in terms of OS to this strategy. Again, the toxicity profile was reassuring. We did not have a lot of MDS or AMLs. It was reported in 3% of patients. So overall, ARIEL4 showed that overall survival actually favored chemotherapy rather than rucaparib in the intent to treat population. I don't know if you can say favored because I'm not sure there was a statistical difference, but essentially we couldn't show a benefit to rucaparib compared to chemotherapy, with a bit of a trend for deleterious OS in the rucaparib arm. I think what this study does, it reinforces if you're going to use a PARP inhibitor, it's better to use it as early as possible and probably in first line. I don't know, Keta, how would you interpret these results?
Oh, Alexandra, as you said, we were completely upset about the results. As you really good underline, it's a different setting. This is a treatment of active disease, and we need not to overlap these results with the amazing results we have in the maintenance setting in first line. And I agree with you. The clear message is that PARP inhibitors should be used as maintenance and in first line. It's difficult to make a judgment about this study. It's difficult because basically more than 90% of patients initially treated with chemotherapy receive a PARP inhibitor after progression. So at the end, it seems like a matter of sequence than a matter of comparison. And also it's difficult to understand why around 45% of patients did not receive any other treatment after progressing in this trial. So these are untreated patients. So these results are very, very difficult to comment and also to interpret. But I agree with you, PARP inhibitors should be used in first-line maintenance setting and not in later line.
Absolutely.
I think that it was a very interesting ESMO, Alexandra, for ovarian cancer. And thank you for being here with me to comment these extraordinary results. And thank you for people attending and listening this podcast.
Yep. Thank you for having me, Keta.
Bye-bye.
Thank you very much, Dr. Lorusso and Dr. Leary, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, 2022 global conference coverage, an update on the clinical development across gynecologic malignancies, and to download a highlights slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.